Hello everyone, my name is Dr. Hester Lacey. Welcome to the next webinar in our series of high-yield UKMLA topics for medical finals. This webinar will cover renal and urology. Just a bit of background about myself. I'm the author of Crash Course Surgery 4th edition. The Crash Course series is a series of high-yield textbooks with core topics for medical finals released by Elsevier, with the new editions all updated to reflect the changes in the UKMLA syllabus. I'm also the ClinicalKey Student Question Bank Assessment Editor. This question bank has over 6,000 high-yield SBA questions relating to medical finals. This webinar series is based on SBA questions relating to individual topics. This webinar will cover renal and urology, with all information included in the webinar relating to NICE guidelines. Here you can see the topics included in the UKMLA syllabus relating to renal and urology. This webinar will have 10 SBA questions relating to these topics in the style of the MLA exam, and we'll go through high-yield information relating to each topic, all coming from NICE and Society guidelines. Let's get started with the first question. A 78-year-old man has 5 days of reduced urine output with fatigue, confusion and lethargy. His temperature is 37.1 degrees C, pulse 98 beats per minute, and blood pressure 102 over 76 millimeters of mercury. He has reduced skin turgor and dry mucous membranes. Which test is most likely to confirm the diagnosis? A. Cystoscopy and biopsy. B. CT, kidneys, ureters, bladder. C. Urine albumin creatinine ratio. D. Urea and creatinine. E. Urinalysis. I'll just give you about 30 seconds to think about the correct answer. The correct answer in this case is D, urea and creatinine, and we'll go through why in the following slides. The diagnosis in this case was an acute kidney injury. An acute kidney injury, or AKI, is a sudden decline in renal excretory function over hours to days, with a subsequent failure to maintain fluid, electrolyte and acid-base balance. There are several risk factors for an AKI. It's very common in older adults. Any patients with a history of AKI or urological obstruction are at increased risk. Comorbidities including CKD, heart failure, liver disease, and diabetes. Acute conditions such as sepsis, hypertension, dehydration, and oliguria. And there are several medications that increase the risk of AKI. A common mnemonic to remember them are the DAM drugs, so diuretics, ACE inhibitors or angiotensin receptor blockers, metformin, and NSAIDs, although many more medications can cause decline in renal function. The causes of AKI are commonly classified into pre-renal, intrarenal or post-renal causes. Pre-renal AKI relates to reduced renal perfusion, which typically relates to hypotension and hypovolemia. Intrarenal causes are those that cause intrinsic and structural kidney damage, and post-renal causes are anything that causes an acute urinary tract obstruction. And here, over to the right, you can see several causes of each of the individual classifications of AKI. Most commonly, AKIs relate to pre-renal causes such as low blood pressure and hypertension from hypovolemia. A diagnosis of AKI can be made several ways, with an increase in serum creatinine over 26 micromoles per litre over 48 hours, an increase in serum creatinine over 50% in 7 days, or a decrease in urine output under 0.5 mils per kilogram per hour for over 6 hours. It's important to always check the baseline creatinine for the patients, as this can change relating to their weight, and any increase of 1.5 to 1.9 times the normal baseline is classified as a stage 1 AKI. There are several stages of severity, which you can see down below, classified by the increase in serum creatinine or the duration and severity of decline in urine output. Classifying AKI is very important for monitoring severity and response to treatment. Once the diagnosis of an AKI is confirmed, it's important to identify the cause. So this involves doing urinalysis to look for any evidence of infection, doing baseline bloods including urea and creatinine, and considering an urgent renal ultrasound to identify any structural or abnormalities or obstruction of the renal tract. Catheterization can be considered if there's any evidence of obstruction, but also to optimize monitoring of urine output over the following days while you're treating the AKI. It's important to optimize the volume status of the patient, which involves resuscitating them if they are hypovolemic, and also considering fluid offloading if they're hypervolemic relating to the AKI. This requires strict input-output monitoring, which may be used with a catheter and a urometer if required. There are several complications of the AKI, such as acidosis and hyperkalemia, that can result with severe AKI, and it's important that you identify and treat these. And any nephrotoxic drugs, like the DAM drugs, should be held in the acute setting. Here on this renal ultrasound, we can see evidence of hydronephrosis with dilation of the urinary pelvis and calyces, which is a fairly sensitive and specific finding for obstruction as a cause of acute kidney injury, resulting in dilation of the renal tract proximal to the obstruction. There are several complications of severe AKI. Several complications are listed here, and these are also indications for dialysis in an acute AKI. They are remembered with the mnemonic AEIOU, where A relates to metabolic acidosis, which is an important feature in severe AKI relating to decreased excretion of acids and decreased renal synthesis of bicarbonates. E, electrolyte imbalances can develop, commonly hyperkalemia, where there's injury to the cells responsible for potassium excretion in the distal nephron and collecting duct. This can result in ECG changes, which are seen on the right here, typically tall tented P waves, decreased or flattened P waves, and a prolonged QRS complex, which will eventually merge with the T wave, forming a sine wave pattern, which will be subsequently followed by ventricular fibrillation or asystole, which can be life-threatening arrhythmias. I relates to intoxication, which can also be an indication for hemodialysis and AKI. O, fluid overload. This can result in peripheral and pulmonary edema due to increased capillary hydrostatic pressure, causing cardiogenic edema. And U, uremia, can develop due to decreased renal excretion of ammonia. These are all indications of hemodialysis. Without treatment, AKI can result in irreversible renal damage and lead to chronic kidney disease. Moving on to the next question. A 71-year-old man has 3 weeks of visible blood in his urine with urinary frequency and urgency. He has hypertension managed with amlodipine and has smoked 30 cigarettes a day for 50 years. Urinalysis demonstrates 3+ blood. Which is the most likely diagnosis? A, bladder cancer. B, benign prostatic hyperplasia. C, interstitial cystitis. D, renal stones. Or E, a urinary tract infection. So I'll just give you about 30 seconds to think about the correct answer. And here, the correct answer is A, bladder cancer. Urinary tract cancer describes a malignancy arising from the bladder, renal pelvis, ureter, and urethra. The bladder is the most common site. They typically relate to a transitional cell urothelial carcinoma. There are several risk factors for bladder cancer. Commonly tested are smoking, exposure to aromatic amines such as dyes, classically those who have worked in a rubber factory, previous pelvic irradiation, which may relate to other malignancy, having a kidney transplant and immunosuppression that comes along with that, and there may be a genetic predisposition. Early stage bladder cancer is commonly asymptomatic and may be picked up when urinalysis performed for another cause as microscopic hematuria. When symptoms do develop, they suggest a later stage disease and may include painless gross hematuria, dysuria, urinary frequency and urgency, evidence of bladder outlet obstruction, suprapubic pain, or a palpable suprapubic mass. NICE recommend referral under a 2-week wait cancer pathway for any patients with the following criteria: dysuria or raised white cell count with unexplained non-visible hematuria aged over 60, visible unexplained hematuria without a urinary tract infection or that persists or recurs after successful treatment of UTI over 45 years, an unexplained recurrent or persistent UTI over 60 years, you can consider a non-urgent referral. The diagnosis of urinary tract cancer is made with evidence of hematuria on urinalysis, decline in renal function or renal function tests, CT urography may be performed, and the definitive diagnosis is made with a cystoscopy and biopsy for histopathological confirmation of the diagnosis. CT TAP is commonly performed for staging. Here we can see a CT scan of the pelvis showing a transitional cell carcinoma involving the right lateral and posterior bladder wall. There may also be evidence of filling defects or hydronephrosis suggesting of intraluminal tumour obstruction and proximal renal tract dilation, mural thickening, or any evidence of disease spread such as lymphadenopathy or distant metastasis. Management of urinary tract cancer, as with all malignancies, involves an MDT approach and considering both the patient wishes and goals of treatment and the stage of malignancy at diagnosis. Non-invasive treatment options include transurethral resection of a bladder tumour. More invasive options involve radical cystectomy with platinum-based chemotherapy. And for those with metastatic disease, palliative platinum chemotherapy is typically advised. Here on the right you can see evidence of a papillary bladder lesion on cystoscopy. Moving on to the next question. A 72-year-old man has 6 months of increased urinary frequency with hesitancy, urgency, terminal dribbling and nocturia up to 10 times per night. He has hypertension and high cholesterol, managed with ramipril and atorvastatin. He has a symmetrically enlarged prostate with a firm, rubbery texture. Which is the most appropriate management? A. Bladder retraining. B. Finasteride. C. Oxybutynin. D. Tamsulosin. Or E. Transurethral resection of the prostate. I'll just give you about 30 seconds to think about the correct answer. The correct answer in this case is D. Tamsulosin. The underlying diagnosis in this case relates to benign prostatic hyperplasia. BPH describes hyperplasia of the transition zone of the prostate. It's very common and affects nearly half of males by age 50. Symptoms relate to both storage and voiding lower urinary tract symptoms, including urinary frequency, urgency and nocturia, incontinence, hesitancy or straining when passing urine, a sensation of incomplete emptying, difficulties initiating the urinary stream and terminal dribbling, and with large BPH can present with acute retention of urine. BPH is a clinical diagnosis and can be confirmed with evidence of prostate enlargement on a digital rectal exam. Typical findings include an enlarged, symmetrical, firm prostate with loss of the central sulcus. The severity of symptoms should be assessed with the International Prostate Symptom Severity Score, which is based on the presence and severity of symptoms in the past 30 days, with up to 7 points suggesting mild symptoms, 8 to 19 points suggesting moderate symptoms, and 20 to 30 points suggesting symptoms are severe. This slide includes an overview of the International Prostate Symptom Score, which has 7 questions relating to symptomatic LUTs, which should be used to score the severity of BPH. These are typical MRI findings in BPH, and here you can see bilateral gross transitional zone enlargement. There are several key steps in the effective management of BPH. Conservative measures are very important, including moderating fluid intake, bladder retraining, reviewing any medications that can contribute to lower urinary tract symptoms, including opioids, TCAs and antihistamines, and reducing caffeine and alcohol as these are irritants to the bladder and can increase the frequency and severity of LUTs. The timing of medications such as diuretics should also be modified to reduce LUTs at night. NICE recommend that you offer an alpha blocker such as tamsulosin to men with moderate to severe LUTs, primarily for symptomatic control, and if symptoms are still problematic after addition of this, antimuscarinics can be considered. 5 alpha reductase inhibitors such as finasteride act in the long term to reduce prostate volume, and these should be offered to males with large prostates or those who are considered to be high risk of progression. The risk of progression is higher in older men and men with poor urinary flow, higher symptom scores, evidence of bladder decompensation such as chronic urinary tension, larger prostates or high PSA levels. Finasteride and tamsulosin can be offered in combination to men with bothersome, moderate to severe LUTs and large prostates. Surgical options include transurethral resection of the prostate, which involves resection of the hyperplastic prostatic tissue around the urethra using a cystoscope. Prostatectomy can be considered for large prostates, and transurethral incision of the prostate can be considered for those with small prostates. However, this is uncommonly used. The most common surgical procedure performed is a TURP, which involves resection of hyperplastic prostate tissue under cystoscope guidance. This is typically indicated after failure of medical management to control symptoms and prostate size. Complications include bleeding, urinary retention, and postoperative UTI. And a key complication is TURP syndrome, which describes dilutional hyponatremia relating to systemic absorption of the large volumes of irrigant used intraoperatively by the open prostatic blood vessels. This can present with severe features of hyponatremia, including seizures. Moving on to the next question. A 62-year-old man has a routine health check. He has type 2 diabetes mellitus and hypertension, managed with metformin, sitagliptin, ramipril, and amlodipine. Investigations performed 6 months ago demonstrated a urea of 12.3, a creatinine of 163 micromoles per litre, and an EGFR of 41. The investigations performed today demonstrate 1+ blood and 1+ protein on urinalysis, a urea of 18, a creatinine of 225, and an EGFR of 34 mils per min. Which is the most likely diagnosis? A. Benign prostatic hyperplasia. D. Bladder cancer. C. Chronic kidney disease. D. Interstitial cystitis. Or E. Urinary tract infection. I'll just give you a few moments to think about the correct answer. And the correct answer in this case is C. Chronic kidney disease. Chronic kidney disease describes a reduction in kidney function or structural kidney damage for over 3 months with associated health implications. The diagnosis is made with markers of kidney damage such as proteinuria, urine sediment abnormalities, electrolyte abnormalities, abnormalities on renal biopsy, any structural abnormalities on imaging, or any previous history of kidney transplantation. Any of these markers associated with a persistent reduction in renal function under 60 mils per minute suggests chronic kidney disease. There are several risk factors for CKD. Key risk factors include hypertension, diabetes mellitus, and cardiovascular disease, and both AKI, nephrotoxic drugs, and obstructive uropathy can precipitate the development of chronic kidney disease. CKD is most commonly asymptomatic until the later stages of severe disease. In late stages, it can cause oliguria, lethargy, itch and muscle cramps relating to reduced renal excretion of toxic metabolites, and patients may have anorexia, vomiting, weight loss, and cachexia. Investigations in CKD include both confirming the diagnosis and assessing for the cause and any associated complications. The diagnosis can be confirmed with serum creatinine, EGFR, and albumin-creatinine ratio. Patients should have their cardiovascular risk assessed with BMI, blood pressure, HbA1c and lipid profile to assess for any contributing comorbidities or complications, and a renal ultrasound may be performed to suggest any underlying cause of CKD. This ultrasound demonstrates polycystic kidney disease. You can see large fluid-filled cysts in the kidneys. Management of CKD primarily relates to modifying risk factors and reducing the risk of progression. Healthy lifestyle advice, including diet and exercise advice with weight loss, should be offered, and nephrotoxic drugs should be avoided. Medical management involves those with a urinary ACR above 30 mg per millimole with hypertension. An ACE inhibitor or an ARB should be prescribed, such as ramipril or losartan. Blood pressure targets relate to urinary ACR at initiation of treatment. Blood pressure for most patients should be maintained under 140 over 90 millimeters of mercury, but for those with severe CKD, there are lower blood pressure targets. Atorvastatin and antiplatelets should be prescribed for cardiovascular disease prevention, and SGLT2 inhibitors can be considered in patients with CKD and type 2 diabetes or with an urinary ACR over 22.6 milligrams per millimole. Longer-term management involves monitoring for disease progression and the development of any complications. Disease progression and severity involves measuring eGFR, and here you can see the staging of chronic kidney disease relating to serum eGFR and urinary ACR. Further tests should include full blood count, calcium, phosphate, vitamin D, and parathyroid hormone levels to assess for any complications. There are several complications relating to CKD. CKD increases the risk of development of an AKI. Electrolyte disturbances can develop, including hyperkalemia and acidosis. CKD increases the risk of development of cardiovascular disease relating to triglyceridemia, hypertension, and heart failure, which can present with pulmonary and peripheral edema. Renal anemia can develop relating to decreased synthesis of erythropoietin, which decreases stimulation of red blood cell production and results in a normocytic normochromic anemia, which may require replacement therapy. Renal mineral and bone disorder or renal osteodystrophy can develop. And ultimately, without effective treatment and modification of risk factors, CKD can progress to end-stage renal disease. CKD is also associated with increased all-cause mortality, highlighting the significance of this diagnosis. This slide provides an overview of how CKD and impaired renal function can cause the development of renal bone disease. Renal bone disease results in hypercalcemia, which ultimately results in increased resorption of bone and weakening of bone, increasing the fracture risk. There are several mechanisms of this. Decreased renal excretion of phosphate relates to hyperphosphatemia, causing calcium phosphate precipitation into tissues and decreasing serum calcium. Decreased renal hydroxylation of vitamin D to the active form reduces intestinal calcium absorption and reduces serum calcium. And chronically decreased calcium levels can cause secondary hyperparathyroidism, which after treatment can progress to tertiary hyperparathyroidism. Moving on to the next question. A 22-year-old woman has 3 hours of severe right loin to groin pain with nausea, vomiting, dysuria, and urinary frequency. Her temperature is 37.1 degrees C, pulse 112 beats per minute, and blood pressure 131 over 89 millimeters of mercury. She is agitated and has severe pain on percussion of the right flank. Which is the most appropriate analgesia? A. Buscopan, B. Codeine, C. Intravenous paracetamol, D. Morphine, or E. PR diclofenac. I'll just give you a few moments to think about the correct answer. And here, the correct answer is E, PR diclofenac. The underlying diagnosis in this case is renal colic, which describes acute severe loin pain resulting from urinary flow obstruction by a urinary stone. The typical presentation involves severe, colicky, unilateral loin to groin pain, which may be described as the worst pain of the patient's life. There may be associated nausea and vomiting, and commonly there may be hematuria, dysuria, and urinary frequency. There are several risk factors for stone formation, which can include age and gender. Stones are most common in males aged between 40 and 60. Dietary factors, including excess intake of oxalate, urate, sodium, and protein. Chronic dehydration, obesity, a family history of stone formation and renal colic, and several features in the medical history, including anatomical urinary tract abnormalities, gastrointestinal conditions affecting the intestinal absorption of nutrients such as Crohn's disease, malabsorptive conditions, or patients having undergone bowel resection, and several genetic conditions. And there are certain medications that can increase the risk of renal stone formation. The approach to a patient with renal colic involves confirmation of the diagnosis with urine dipstick and CT-KUB. Analgesia should be prescribed, and with NSAID analgesia typically recommended as they reduce ureteric peristalsis and edema. The PR route with PR diclofenac is known to be highly effective in these cases. Patients should be resuscitated if there is any associated hemodynamic instability, and empirical antibiotics can be prescribed if there is evidence of superimposed systemic infection or sepsis. On this CT scan, we can see a stone in the right renal pelvis. Definitive management of renal stones relates to the stone size. For small stones in patients who are minimally or otherwise asymptomatic, stones can be managed with watchful waiting as they will be excreted spontaneously. If there is a distal stone, which is below 10 millimeters, medical expulsive therapy with tamsulosin can be recommended. But if there is any uncontrolled pain or failure to pass the stone spontaneously, surgical management is recommended, with extracorporeal shockwave lithotripsy, percutaneous nephrolithotomy, or urotoscopy, and open surgery in the failure of any of these above measures. This flowchart provides an overview of the management of renal colic, involving both confirmation of the diagnosis, initial resuscitation, and definitive management. If there is unretractable pain or large stones, patients should be referred to urology for intervention. For urethral stones, typically shockwave lithotripsy or urotoscopy are performed. Shockwave lithotripsy involves focusing shockwaves on the stone to break it up, the particles are then passed spontaneously. And urotoscopy is a similar procedure which involves the use of energy sources such as lasers to break up the stone. Percutaneous nephrolithotomy can be used for very large stones or those placed in the lower renal pole, and involves use of a nephroscope passed percutaneously into the collecting system to fragment the stone and then extract it. Moving on to the next question. A 65-year-old man has 6 months of fatigue, breathlessness, and lower leg swelling. He has type 2 diabetes mellitus, managed with metformin, sitagliptin, and gliclazide. He has dull percussion in the lung bases and reduced air entry, with pitting edema to mid-calf. Investigations demonstrate 3+ protein on urinalysis and an eGFR of 29 mL per minute. Which is the most appropriate management? A. Furosemide, B. Hemodialysis, C. Optimized glycemic control, D. Prednisolone, or E. Nitrofurantoin. I'll just give you a few moments to think about the correct answer. And here, the correct answer is C, optimization of glycemic control. The underlying pathology in this case relates to diabetic nephropathy, which describes chronic renal microvascular injury relating to systemic hyperglycemia, typically developing as a result of long-term inadequate management of blood glucose levels. It's common and develops in 20% of patients with diabetes Hence, patients with diabetes should be annually monitored for the development of this with urinary ACR and EGFR screening. Diabetic nephropathy is the most common cause of nephrotic syndrome in adults with diabetes. The diagnosis is made when there is over 3 months of persistent reduction in kidney function with an EGFR under 60, or evidence of persistent proteinuria with a urine ACR above 3 mg per millimole. And on the right here, you can see some of the histological changes seen in the kidney in diabetic nephropathy. The most important aspect of management of diabetic nephropathy is optimization of blood glucose levels with effective management of diabetes. For patients with chronic kidney disease stage 3 or above, patients should also be offered lipid reduction with atorvastatin, blood pressure control with an ACE inhibitor or an angiotensin receptor blocker with the targets as same as those outlined for the management of chronic kidney disease. Dapagliflozin can be offered if the EGFR is between 25 to 75 mL per minute at the start of treatment. And finerenone can be considered, which is a non-steroidal mineralocorticoid receptor antagonist that inhibits receptor-mediated sodium resorption and decreases receptor overactivation, reducing inflammation and fibrosis that lead to kidney damage and diabetes. This should be considered if renal function is not improving with an ACE inhibitor and ARB and the SGLT2 inhibitor. Moving on to question 7. A 62-year-old man has 2 months of shortness of breath, reduced urine output and lower leg swelling. He has multiple myeloma managed with chemotherapy with paracetamol and oxycodone for pain. He has pitting edema to the mid-shin. Investigations demonstrate a hemoglobin of 92, calcium of 2.84, a urea of 21 and a creatinine of 361, and EGFR of 28 mL per minute. Which complication has most likely developed? Is it A, AL amyloidosis, B, analgesic nephropathy, C, hypercalcemia associated renal damage, D, myeloma-cast nephropathy, or E, type 1 cryoglobulinemia? I'll just give you a few moments to think about the right answer. The correct answer in this case is D, myeloma-cast nephropathy. Just running through some of the other incorrect options quickly. AL amyloidosis is a systemic amyloidosis relating to a plasma cell proliferative disorder, commonly multiple myeloma, which results in abnormally folded immunoglobulin light chain proteins into tissues, which can include the kidney, and can progress to renal amyloidosis and CKD. Analgesic nephropathy typically relates to chronic use of NSAIDs or opiates, resulting in accumulation in the kidneys and subsequent renal impairment. Hypercalcemia-associated renal damage can relate to severe untreated hypercalcemia, resulting in nephrocalcinosis and eventually renal failure, that typically results from calcium levels over 3 for several months. And type 1 cryoglobulinemia is an immune-mediated deposition of monoclonal antibodies into blood vessels, which is associated with monoclonal gammopathy such as multiple myeloma. Deposition into renal vessels can produce renal impairment and EGFR reduction. Multiple myeloma describes malignant proliferation of abnormal plasma cells in the bone marrow and accumulation of abnormal monoclonal immunoglobulins in the blood. There are several key features, including constitutional features of malignancy such as fatigue and weight loss, recurrent infection relating to immunosuppression resulting from the abnormal immunoglobulins. Hypercalcemia can develop due to bone lysis by myeloma cell-mediated promotion of osteoclast bony destruction and inhibition of osteoblast-mediated bone anabolism. This can result in hypercalcemia, which can present with confusion, weakness, constipation, thirst, polyuria, and bone pain. And vertebral fractures, with the bony lytic lesions that are commonly seen, can produce features of spinal cord compression if the cord is compromised, including sensory loss, paresthesia, limb weakness, walking difficulty, and sphincter disturbances. Hyperviscosity can develop due to the presence of large molecular proteins in the blood, which can present with features of headache, visual disturbance, cognitive impairment, mucosal bleeding, breathlessness, and venous thromboembolism. Key findings in investigation of patients with suspected multiple myeloma involve a normochromic normocytic anemia on full blood count and blood film, evidence of renal impairment, hypercalcemia, a raised erythrocyte sedimentation rate, serum paraprotein bands on serum urine electrophoresis, raised serum free light chains, and evidence of Bent chain proteins. There may be associated liver impairment, and X-rays of symptomatic areas should be performed to look for bony lytic lesions. Patients with serum urine protein electrophoresis suggestive of myeloma should be urgently referred to haematology under the 2-week wait rule. Serum electrophoresis demonstrates abnormal accumulation of paraproteins in the blood, which can be seen as paraprotein bands. Patient 1 has IgM paraprotein, patient 2 IgA, and patient 3 IgG. On the left, you can see a sample from the bone marrow in myeloma, which demonstrates malignant plasma cells of varying degrees of maturity and rouleau formation, which is demonstrated by the cells grouped in chains. Marked rouleau formation is often a clue to the diagnosis of a plasma cell neoplasm. On the right, we can see X-rays of the left radius and ulna in a patient with myeloma, and you can see numerous lytic lesions in the bone. There are a number of complications of multiple myeloma, which are typically remembered with the acronym CRAB, which stands for hypercalcemia, renal damage, anemia, and pathological bone fractures. Renal damage most commonly relates to myeloma cast nephropathy, which results from excessive renal filtration of the light chains and accumulation in the glomerulus. Hypercalcemia is associated with its own complications. Pathological bone fractures can cause further complications, as mentioned previously, such as spinal cord compression. And there are other key complications to be aware of, including relative immunosuppression and increased risk of infection, and bleeding disorders and increased hyperviscosity of the blood, which can lead to VTE. Myeloma cast nephropathy relates to accumulation of free immunoglobulin light chains in the renal tubules with formation of urinary casts that produce cast nephropathy and renal failure. It's the most common cause of renal failure and myeloma. And here you can see the demonstration of renal myeloma cast nephropathy on renal biopsy. Myeloma is an incurable disease, although advances in treatment mean that disease control can be achieved for several years. Management of disease involves use of chemotherapeutic agents, steroids, immunomodulatory drugs, and stem cell transplantation, and treatment of complications, including bisphosphonates to reduce bone disease and pain, treatments for anemia, including EPO replacement or blood transfusion, antibiotics for infection, effective management of pain, and VTE prophylaxis. Patients with symptomatic multiple myeloma, which suggests active disease, should be reviewed by a haematologist at least every 3 months. And people with asymptomatic or smouldering multiple myeloma diagnosed with investigations only, with no active complications or symptoms, should be reviewed every 3 months for the first 5 years of disease, with the frequency thereafter depending on the long-term stability of disease features. Moving on to question 8. A 68-year-old woman has 7 months of involuntary leakage of urine when sneezing and coughing, with urinary frequency and nocturia. She has type 2 diabetes mellitus, managed with metformin, and takes nitrofurantoin for recurrent urinary tract infections. Her abdomen is soft and non-tender. Which is the most likely diagnosis? A. Interstitial cystitis. B. Pelvic organ prolapse. C. Stress incontinence. D. Urge incontinence. Or E. Urinary tract infection. I'll just give you a few moments to think about the correct answer. The correct answer in this case is E, stress incontinence. Incontinence describes the involuntary leakage of urine. Stress urinary continence describes involuntary leakage of urine on effort, exertion, sneezing, or coughing, and relates to pelvic floor weakness. Urgency urinary incontinence describes involuntary leakage with a sudden compelling desire to pass urine, described as urgency. There is an overlap with overactive bladder syndrome, which presents with urgency with or without incontinence associated with urinary frequency and nocturia. Mixed urinary incontinence describes patients with features of both stress and urgency incontinence, and overflow incontinence relates to detrusor muscle underactivity or bladder outlet obstruction with urinary retention and involuntary leakage of urine. While there is no single cause for stress urinary incontinence, there are a number of risk factors which predispose people to developing this condition. These include increasing age, pregnancy and vaginal delivery, which can result in weakening of the muscles and connective tissue in the pelvic floor or damage to the pudendal and pelvic nerves. Obesity increases the pressure on pelvic tissues, resulting in stretching and weakening of the muscles and nerves. Constipation and associated chronic straining can weaken the pelvic floor muscles. There may be a deficiency in supporting tissues relating to a prolapse, a previous cystectomy, or reduced estrogen, commonly around the menopause. There may be a family history of stress incontinence. Patients with a chronic cough can contribute to stress incontinence, and hence smoking is a risk factor. And there are certain medications, for example ACE inhibitors, that can contribute to a chronic cough and worsen stress incontinence. Here we can see an overview of the pathophysiology of stress incontinence. A describes the bladder at rest. B demonstrates intra-abdominal pressure, which is normally transmitted to both the bladder and the urethra. And C demonstrates the mechanism of stress incontinence, where intra-abdominal pressure is only transmitted to the bladder and not the urethra, resulting in urinary leakage. The approach to patients presenting with features of stress incontinence should involve determining the cause with a history and examination, and determining severity with a bladder diary, which should document the amount, type and timing of fluid drank, the voided volume, the frequency of micturition, episodes of urgency or incontinence, any activities causing leakage, and any pad or clothing changes. Management involves modification of lifestyle factors with moderation of fluid intake, weight loss, and smoking cessation. Reducing caffeine intake is also important, as this can improve symptoms of urgency and frequency. And the first line management for stress incontinence involves 3 months supervised pelvic floor muscle training, involving at least 8 pelvic floor muscle contractions performed at least 3 times a day. Surgical options can be indicated if there is a failure of pelvic floor muscle training, including copper suspension or use of fascial or mesh slings, or urethral bulking agents. Duloxetine can be considered, but only if surgical intervention is not possible. Moving on to question 9. A 26-year-old man has 5 weeks of a right groin lump with dull scrotal discomfort. He is otherwise well. He has a 3 centimetre firm lump on the right testis, which does not transilluminate. Which test is most likely to confirm the diagnosis? A. Alpha-fetoprotein. B. Fine needle aspiration. C. Nucleic acid antigen testing. D. Testicular ultrasound. Or E. Urinalysis. I'll just give you a few moments to think about the correct answer. The correct answer in this case is D, testicular ultrasound, as we are suspecting an underlying diagnosis of testicular cancer. Testicular cancer is the most common solid tumour detected in males aged between 15 to 34 years. In children, this commonly relates to a yolk sac tumour or a teratoma. In adults, tumours are typically germ cell, mainly teratomas and seminomas. Risk factors include being of white ethnicity, a family history of testicular cancer in a first-degree relative, undescended testes known as cryptorchidism even after orchidopexy surgery, hyperspadias, subfertility or infertility, patients with Klinefelter syndrome, and any patients with a contralateral tumour are at increased risk of ipsilateral disease. Symptoms of testicular cancer involve unilateral testis enlargement or change in shape or texture. It is often painless, but there may be a dull ache or a dragging sensation in the scrotum. Patients may have a solid, firm mass involving all or part of the testes with associated scrotal swelling. There may be supraclavicular or retroperitoneal lymphadenopathy, and there may be associated hydrocele or epididymal orchitis. Any patients with clinically suspected testicular cancer should be urgently referred to urology. To support the diagnosis, tumour markers can be performed, including alpha-fetoprotein, human chorionic gonadotrophin, and LDH, which may all be raised. These all support the diagnosis. But to confirm the diagnosis, an ultrasound must be performed, which will delineate the lesion. CT staging should be performed, and biopsy should not be conducted as there is a risk of tumour seeding. Hence, the diagnosis is confirmed histologically following radical inguinal orchiectomy. These are some typical ultrasound findings. This is a patient with a seminoma. Here in this ultrasound of the left testicle, you can see a lobulated, heterogeneous, hypoechoic mass occupying most of the testicular space, suggestive of seminoma. Moving on to the final question. A 32-year-old man has 6 weeks of dull right scrotal pain and swelling after 3 episodes of severe scrotal pain, swelling and fever in the past year. He has tenderness and swelling of the right hemiscrotum with thick, palpable epididymis. Which is the most likely diagnosis? A. Chronic epididymitis, B. Hydrocele, C. Inguinal hernia, D. Orchitis, or E. A varicocele. I'll just give you a few moments to think about the correct answer. The correct answer in this case is A. Chronic epididymitis. Epididymitis and orchitis describe pain, swelling and inflammation of the epididymis and or the testis. Epididymitis and orchitis can commonly present in conjunction with each other. There are a number of infectious and non-infectious causes. In children, the most common cause is secondary inflammation relating to a recent viral infection or structural or functional abnormalities of the urinary tract causing urine reflux and urinary tract infection. In patients aged between 14 to 35, the most common cause are local spread of sexually transmitted infections such as chlamydia or gonorrhea from the urethra. And in patients over 35, the most common cause are spread of enteric organisms such as E. coli from the bladder. And things increasing the risk of this include recent surgery or instrumentation, a persistently positive urine dip, or any structural abnormalities of the renal tract. Epididymitis and orchitis presents with acute unilateral scrotal pain and or swelling. Associated fever, dysuria, urethral discharge, and parotid swelling may occur in mumps orchitis. There will be palpable tender swelling of the epididymis and testes, erythema of the scrotal skin, scrotal pain and tenderness relieved by elevation of the testis, which is known as Friend's sign, and there may be an associated hydrocele. Here we can see the typical presentation of epididymitis with erythema and edema on the affected side. Management of epididymitis and orchitis involves identification of the causative organism with urine dip and MSU, nucleic acid antigen testing in the appropriate demographic, and for patients with a likely STI organism, management should involve referral to a gum clinic and empirical treatment with IM ceftriaxone for gonorrhea or oral doxycycline for chlamydia, or both. And for patients with likely enteric organisms, patients should be prescribed oral levofloxacin or coamoxiclav. Supportive measures include scrotal support, warm baths, and analgesia. There are a number of complications of epididymitis and orchitis, which can include epididymal abscess, infertility, or the development of chronic epididymitis, which describes epididymal inflammation without infection for over 6 weeks. If patients are presenting with over 6 weeks of scrotal pain and swelling, with a thickened epididymis and multiple episodes of previous acute epididymal orchitis, this is highly suggestive of this diagnosis. Risk factors include repeated urinary tract infection or sexually transmitted infection, catheterization, and recent genitourinary surgery. Symptoms include low-grade testicular ache, which radiates to the groin, perineum, or thigh. It is a clinical diagnosis, and management involves ibuprofen, supportive underwear, and any antibiotics if there is evidence of any infection. That brings us to the end of this webinar on high-yield UKMLA topics relating to renal and urology. Today we have covered acute kidney injury, bladder cancer, benign prostatic hyperplasia, chronic kidney disease, diabetic nephropathy, urinary tract calculi, myeloma, incontinence, testicular cancer, and epididymitis and orchitis. Thank you very much for joining, and looking forward to seeing you next time.